Good morning, dear fourth year students. Today we have the sixth hematology lecture, and the topics will be Hodgkin disease, non-Hodgkin lymphoma, and plasma cell myeloma. The objectives of this lecture, by the end of this lecture, the student should be able to, one, recall a broad classification of Hodgkin disease and non-Hodgkin lymphoma, two, describe the clinical presentation and diagnosis of Hodgkin disease and non-Hodgkin lymphoma and the principles of treatment. And three, describe briefly the clinical features, diagnosis, and the treatment of a plasma cell myeloma. So as usual, we start with a case scenario. A 20-year-old female presented with 8-week history of intermittent fever, multiple cervical and axillary lymph nodes. Her clinical examination revealed her to be febrile, pale with multiple cervical lymph nodes and slightly enlarged spleen. What's your differential diagnosis? As you can see from this scenario, the possibilities are either lymphoma, could be Hodgkin disease or non-Hodgkin lymphoma. Also, leukemia, acute leukemia, can be in the differential diagnosis. Also, chronic lymphatic leukemia can be in the differential diagnosis. So as you see, you can cast your vote. Hodgkin disease is defined as a lymphoproliferative disorder of B lymphocytes. The hallmark is the presence of what is called red stem cells in the involved organs, mostly lymph nodes. And I suppose that you have an idea about the red stem cells. These cells originate from B lymphocytes. They are large in size. They have clear cytoplasm, and the nucleus is binucleated, and there is a nucleolus inside the nucleus, and these cells are scattered inside the lymph nodes. Also, these cells can be seen in other tissues if it is involved by the Hodgkin disease. Males are slightly more affected than females. The etiology is not clear, but it seems that Epstein-Barr virus infection may have some role because the DNA of the Epstein-Barr virus have been found inside the cells of Hodgkin disease. Pathological classification, we have the nodular lymphocyte predominant, which is a rare entity. It forms 5% of the affected people with Hodgkin disease. It is a slowly growing disease. It is usually localized and rarely fatal. The second type is the classical Hodgkin lymphoma, which has four subclasses: the nodular sclerosing, which forms around 70% of classical Hodgkin lymphoma. It is common in young females and mostly present with large mediastinal mass that may end with supervena cava obstruction. The second subtype is the mixed cellularity. It forms around 20% of cases. It is more in the elderly, and it has a worse prognosis. The lymphocyte rich, this variety has good prognosis. It forms around 5% of cases, and it is more common in males. And we have the lymphocyte depletion type, which is rare, but this is a fairly more aggressive variant. Usually, the disease is widely spread at diagnosis, and the course is in many patients is aggressive. The clinical features of Hodgkin disease, the most common presenting feature is lymphadenopathy, localized or generalized, and the lymph nodes are usually painless, mobile, and rubbery. The most common site involved is the neck, the mediastinum, and the axilla, but also abdominal lymph nodes and inguinal lymph nodes can be involved. Less frequent sites involved include hepatomegaly, splenomegaly, mediastinal mass, supravena cava obstruction, pleural effusion, spinal cord compression, and bone marrow involvement, which is rare. Systemic B symptoms reflect the effect of the Hodgkin lymphoma on the body. The B symptoms include fever, weight loss more than 10% over 6 months, and excessive sweating. The presence of B symptoms in many patients indicates worse prognosis. Other presentations can be pyrexia of unknown origin or severe itching without a skin rash, and after a time, a lymph node will appear, and we can diagnose these patients with Hodgkin disease. The diagnosis depends on pathological diagnosis. We should have a report of a tissue biopsy, usually a lymph node, but still from the bone marrow if it is involved, or from the pleura. Um, the lymph node section will show loss of the normal node architecture, infiltration of inflammatory cells, especially lymphocytes and plasma cells, and the presence of red Sambic cells. When we use immunohistochemistry, we study the CD markers of these cells. These cells are usually positive for CD15 and CD30 in classical cases. So these cells are CD15 positive and CD30 positive. When we confirm the diagnosis, next step we go for staging procedure. The purpose of doing staging is to find the extent of spread of the disease in the body of the patient, because it will affect the choice of a treatment. For staging, we need good history and detailed physical exam. We should examine all the lymph node areas, the blood picture. Usually in Hodgkin disease, the patient will have lymphopenia, and some patients may have high ESR, and in severe cases or in extensive cases, we may find anemia. We should check the renal and liver function. The serum albumin and serum LDH are very useful because patients with aggressive disease or bulky disease, the serum albumin is reduced and the serum LDH is increased. Also, we need to do chest X-ray and ultrasound of abdomen. Sometimes in the chest X-ray, we find mediastinal widening because of mediastinal lymphadenopathy. And by ultrasound of abdomen, we can find sometimes enlargement in the para-aortic lymph nodes, or we may find enlargement in the liver and spleen. Now we use a better radiological study, which is the spiral CT scan of the neck or chest and abdomen, or we use a PET CT scan, which can discover small areas of involvement that cannot be discovered by the usual radiology. Bone marrow study is not routinely done unless the patient is having anemia or pancytopenia, or the patient is if the patient is enrolled uh, in a new drug trial. In this photo, we can see the red stem cell. As you see, it is a large cell with clear cytoplasm, two mirror image nuclei with a nucleolus inside them. These cells are rare in the nodular sclerosing and lymphocyte-rich variety, but they are easily seen in patients with lymphocyte depletion and mixed cellularity types. And in this chest X-ray, you can see mediastinal widening because of enlarged mediastinal lymph nodes. And if the mediastinal lymph nodes are pressing on the superior vena cava, the patient can present with superior vena cava obstruction. This photo shows PET-CT scan. In photo B, we can see the black areas with arrows indicating enlarged and involved lymph nodes. And on the left, the photo A shows the normal PET-CT after the patient had received the treatment. Also, we can see in C and in D and in E involvement of especially in D, we can see involvement of the ribs by the enlarged lymph nodes. The staging system that we use is called the Ann Arbor staging. We have 4 stages. Stage 1, if the patient is having single lymph node region involved. Stage 2, if 2 or more lymph node regions are involved, but they should be on the same side of the diaphragm. Stage 3, more than one lymph node region is involved on both sides of the diaphragm, above and below diaphragm. Stage 4, when there is a diffuse involvement of an extra lymphatic tissue like the liver or the bone marrow and the lung. For each stage, we have substage A without B symptoms, and substage B when there are B symptoms that I mentioned: weight loss, drenching, sweating, and fever. What is the definition of lymphatic structures? These include lymph nodes, spleen, thymus, Waldeer rings, and the appendix, also included in the definition of lymphatic structures. Staging of lymphoma by photos: stage 1, stage 2, two areas are involved on the same side of the diaphragm. Stage 3, on both sides of the diaphragm. And stage 4, there is diffuse involvement in the liver or spleen or bone marrow and so on. The treatment of Hodgkin disease, we have the treatment modalities, the chemotherapy. We use the protocol. Its abbreviation is ABVD. It is a composite of 4 chemotherapeutic medications. They are given every 28 days. We have the radiotherapy. We have the monoclonal antibodies, anti-CD30, brentuximab, and we have the autologous bone marrow transplant or the allogeneic bone marrow transplant. How are we going to choose which modality fits the patient? We depend in planning treatment on the stage of the disease. For stage 1 and stage 2, we use the ABVD 3 to 4 cycles and combined with involved field radiotherapy. More than 90% will go into complete remission. While stage 3 and 4, also we use ABVD, but we use for more courses, 6 to 8 courses. Radiotherapy in these conditions is not much useful because the disease is widespread, but still we can get good results. 80% of patients will go into complete remission. After we finish the treatment, we restage the patient using PET-CT to find if there is any residual disease. If the patient is having no residual disease, the patient is scheduled for follow-up every 3 months. The patient will come for studying we take history, we do physical exam, and we send the patient for chest X-ray and ultrasound of the abdomen. If there is any suspicion, we repeat the PET-CT scan. For relapsed patients who relapse after initial response, we give second-line chemotherapy to achieve another remission to be followed by autologous bone marrow transplant. For patients who are resistant to treatment, we use anti-CD30 antibodies, and when we achieve remission, we offer the patient allogeneic bone marrow transplant from a sibling. Not all patients can get a bone marrow transplant because if the patient is elderly and is having comorbidities, or if the patient is not responding to treatment, the allogeneic bone marrow transplant will become risky. Another modality is now in evolution that uses what is called CAR T cell therapy, which is an investigational and inexpensive treatment. It is used to treat patients with refractory Hodgkin disease, but still it is present in a few centers in the world. This is the principles of CAR T cell therapy. It depends on collecting autologous uh, lymphocytes from the patient, and they are primed against the antigens of the malignant cells and re-infused in the blood of the patient to kill these cells. The prognosis, there are certain factors that indicate a poor prognosis in the patient, like advanced stage, patients with more than 45 years of age, males, they do worse with the Hodgkin disease, lymphocyte depletion subtype, and the presence of high ESR, severe lymphopenia, anemia, low serum albumin, bulky mediastinal mass, and high serum LDH. All these indicate poor prognosis. Also, if the patient is resistant to treatment or develops relapse in the first year after getting remission, also indicates bad prognosis. This is what is called the survival curve for patients with Hodgkin disease. It is done according to the stage of the disease, the blue line for stage 2, the green line for stage 3, and the red line for stage 4. You can see that the survival is better with the stage 2, followed by stage 3, and then the worst is the stage 4. Now we come to the other important group of lymphoma, which is the non-Hodgkin lymphoma. The non-Hodgkin lymphoma is a heterogeneous group of malignant diseases that arise in the lymphoid tissue. The classifications of these lymphomas uh, occurs every few years because a new subtypes appear and changes in the molecular and molecular genetics and cytogenetics. The classification, the most recent classification, what is called the updated real WHO classification, uh, we classify the non-Hodgkin lymphoma into B-cell neoplasms. It has many subtypes. You are not requested to memorize all of them, but we are going to select a few common entities for discussion. We have the T cell and natural killer cell neoplasm, also many varieties. The T cell is less common than B cell varieties. So, B non-Hodgkin lymphoma forms around 70% of cases, while the T cell non-Hodgkin lymphoma forms 30% of cases. What is the etiology of non-Hodgkin lymphoma? It is not very clear why non-Hodgkin lymphoma develops, but there are certain observations that help us to understand the etiology. The non-Hodgkin lymphoma can develop as a late manifestation in patients with HIV infection. Other viral infections rarely can end with lymphoma, like Epstein-Barr virus infection and human T lymphocyte virus infection. H. pylori, which affects the stomach, can result in gastric lymphoma. A chronic hepatitis C virus infection can result in the development of splenic lymphoma. Uh, Also, certain cytogenetic abnormalities like chromosomal translocations, like translocation chromosome 14, 18 is associated with follicular lymphoma. Patients who are immune suppressed, like patients who have renal transplant or liver transplant, they can develop lymphoma, and also patients with congenital immune deficiency states. In the non-Hodgkin lymphoma, the most important factor is the grade, the type and the grade of the lymphoma, whether it is high grade or low grade. The grade means the rapidity of the rapidity of development of lymphoma. Some, type, some types of lymphoma, they are called high-grade lymphoma. They have high proliferation rate. They rapidly produce symptoms and they are fatal if not treated. But if they are treated properly, especially if we catch the patient early, they are potentially curable. While the low-grade non-Hodgkin lymphoma, it has a low proliferation rate, and sometimes it may go asymptomatic for many years before presentation. The course is indolent, is slowly progressive, but unfortunately these lymphomas cannot be cured. 85% of high-grade non-Hodgkin lymphoma is the diffuse large B-cell lymphoma or low-grade follicular lymphoma. So you can see that the most common subtypes are the diffuse large B-cell lymphoma and the low-grade non-Hodgkin lymphoma, what is called the follicular lymphoma. Other forms include the mantle cell lymphoma and marginal zone lymphoma are less common. The hallmark of B-cell non-Hodgkin lymphoma is positive B-cell CD markers, which are the CD19, CD20, and CD79, A and B. The indolent type of B-cell non-Hodgkin lymphoma, these are slowly progressive or non-curable, as I said. They include the follicular lymphoma, the mantle cell lymphoma, and the extranodal marginal zone lymphoma, what is called the maltoma. This type involves the stomach. And we have the aggressive group, which is rapidly progressive and potentially curable, like a precursor B, acute lymphoblastic leukemia. You see that acute lymphoblastic leukemia is grouped with the lymphoma because its variety, what is called the lymphoblastic lymphoma, it behaves like lymphoma, or it can behave as acute leukemia. We have also from the aggressive group, the diffuse large B-cell lymphoma, which is the most common type of non-Hodgkin lymphoma. And we have the Burkitt lymphoma, which is a very aggressive non-Hodgkin lymphoma that usually affects children and young people. The indolent subtypes, they have remissions and relapses, but the patient can live for a long time, around 10 years. While the aggressive non-Hodgkin lymphoma, 80% of them, they respond initially to treatment, but only 35% of them, they have a cure at 5 years. That's to say, 1/3 of patients with aggressive B-cell non-Hodgkin lymphoma can be cured by chemotherapy. The T-cell and natural killer non-Hodgkin lymphoma, as classified by behavior, first of all, the hallmark of T-cell lymphoma is T-cell markers, which are the CD3, CD4, and CD8. The indolent subtypes also are slowly progressive but non-curable. The best example is mycosis fungoides and Sézary syndrome, in which the T-cell non-Hodgkin lymphoma involves the skin. We have the aggressive subtype, which is rapidly progressive, potentially curable, like precursor T-cell acute lymphoblastic leukemia and lymphoblastic lymphoma, anaplastic large cell lymphoma, and peripheral T-cell lymphoma. So you see in each type of lymphoma, whether it is B or T, there is a group which is indolent, slowly progressive, and there is a group which is aggressive. So now you should be able uh, to give a statement about how can we prove that this patient is having Hodgkin disease rather than non-Hodgkin lymphoma. By the presence of mediastinal mass, the presence of splenomegaly, the presence of red stem cells in the lymph node section, or if the lymphoid cells carry CD20 markers. Cast your vote. It is very clear that we depend on the presence of red stem cells in the lymph node section. It helps to differentiate between Hodgkin disease and non-Hodgkin lymphoma. Indolent B-cell lymphoma, examples, follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma. As I said, it is a slowly progressive disease, and sometimes it may resemble chronic lymphatic leukemia with lymphadenopathy and hepatosplenomegaly and anemia, pancytopenia also, and sometimes, on the contrary, the patient may have lymphocytosis. The lymphoma cells will spill in the bloodstream, giving a picture very similar to chronic lymphatic leukemia. Sometimes these patients develop jaundice and immune hemolysis. The diagnosis depends on finding infiltration by malignant lymphoid cells with B cell CD markers. The blood picture may show anemia, especially if there is immune hemolysis, but could be non-immune cause. Sometimes we find pancytopenia or lymphocytosis. The bone marrow is involved early in this type of non-Hodgkin lymphoma. If we do a CT scan of the chest and abdomen, we may find widespread lymphadenopathy. It is important to check the renal function and liver function. The staging is similar to Hodgkin disease, but usually we don't depend much on the stage, the Ann Arbor stage. We use what is called the IPI score, the International Prognostic Index score. And this score, we depend on the age of the patient, on the stage of the disease, on the serum LDH, the number of extranodal sites involved. As I said, this group of lymphomas, the indolent B cell lymphoma, they are not curable. Therefore, for patients who are asymptomatic, we may put the patient under observation, and the treatment will be given when the patient starts to get symptoms or the disease starts to progress. For symptomatic patients, we use the following treatment modalities: monoclonal antibodies, like anti-CD20 antibodies, we call it rituximab, alkylating agents, plus prednisolone. A lot of alkylating agents are present, fludarabine, or combination of the above modalities. Radiotherapy is reserved for patients with superior vena cava obstruction or early localized disease. This photo shows the follicular lymphoma. We can see pseudofollicles inside the lymph nodes. These pseudofollicles are filled with lymphoma cells. And you see that the survival of follicular lymphoma depends on the IPI score. Patients with low IPI score, 0 to 1, will have better survival if we compare them for patients with high IPI score, 4 to 5. The aggressive B-cell non-Hodgkin lymphoma, the clinical presentation is rapidly progressive disease. The best example is diffuse large B-cell lymphoma. It can affect both genders and different age groups. Patient may present with cervical lymphadenopathy or even extranodal involvement. Bone marrow involvement occurs later in the disease, not from the early beginning like in indolent non-Hodgkin lymphoma. It can present just like Hodgkin disease with obstruction, superior vena cava obstruction or obstructive jaundice, and even CNS involvement can occur. Systemic B symptoms are common. The diagnosis depends on finding B cell markers on the lymphoid cells. As I said, CD19, CD20, and CD79B. Prognosis depends on the IPI score. The treatment, the disease is potentially curable, so we try to give the patient aggressive chemotherapy from the start. The best regime is rituximab plus CHOP. CHOP is abbreviation of 4 medications. Local radiotherapy is given for obstructive lesions, and patients who relapse, just like Hodgkin disease. Patients who relapse after first remission, they are given second-line treatment followed by autologous bone marrow transplantation. The bad prognostic signs include old age, high serum LDH, extranodal involvement, and bulky disease. The other subtype is Burkitt lymphoma. Burkitt lymphoma is a very aggressive B-cell lymphoma. It can present in children with abdominal or jaw mass, or it may present an acute leukemia-like picture. It is treated aggressively with multi-agent chemotherapy, and a cure is possible if the patient tolerates the treatment. But sometimes the patient may die quickly because of the complications of the aggressive disease. This is the photo of lymph node biopsy section with diffuse large B-cell lymphoma. We see that there is infiltration of the lymph node by malignant large size B lymphocytes. And as you see, according to the stage, patients with stage 2, less than stage 2, like stage 1, they do better with the treatment if we compare them with patients with stage 3 and 4. The cutaneous T-cell lymphoma, this is an indolent T-cell lymphoma. It is a malignant disease of the helper T lymphocytes in the skin. The cause is usually indolent. The patient presents with itching and skin macules, which then enlarge to become nodules. The peripheral blood involvement is rare, but if we find lymphoid cells in the peripheral blood, we call it Sézary syndrome. Visceral involvement is very rare and occurs late in the disease. Treatment depends on giving the patient soraline plus UV light, we call it PUVA, topical corticosteroids, low-dose methotrexate, phototherapy, alpha interferon, and vitamin A analogs. It is an indolent disease. It can persist for 10 years or more. And in this photo, you can see the patches of infiltration of the malignant lymphocytes in the ectoderm, or in the epidermis. Now we come to the plasma cell myeloma. Plasma cell myeloma is also a neoplastic disease that is derived from B lymphocytes. There is a clone of plasma cells that produce abnormal monoclonal immunoglobulin. The clone proliferates in the bone marrow and results in skeletal destruction with osteolytic lesions, osteopenia, and fractures. It is a rare malignant disease. It forms 1% of all malignant diseases, slightly more frequent in males. The median age of diagnosis is 66 years. Median survival improved greatly with the new modalities of treatment. The clinical presentation, the disease is slowly progressive and deceiving. It can deceive us in the beginning. The patient may present with fatigue, bone pain, pain in the spines and the ribs that sometimes is attributed to hematological diseases. The patient also may present with anemia, and ultimately the patient will present with pathological fractures, like fractures in the spine, in the long bones, and ribs. The patient is having repeated infections due to loss of the normal immunoglobulins, and the most common infections are the pneumonias and urinary tract infection. There may be weakness and numbness in the limbs, hyperviscosity, and manifestations of a hypercalcemia like polyuria, abdominal pain, and constipation and confusion. The laboratory investigations include normocytic normochromic anemia, formation. More than 50% of patients will have a very high ESR, more than 100. There is increased blood urea, serum creatinine, and uric acid. and calcium in some patients. In the serum protein electrophoresis, we may find what is called monoclonal protein or M protein. This is an abnormal immunoglobulin, mostly IgG, but could be IgA or IgD. If we do immunoglobulin assay, we find that there is reduction of the normal immunoglobulins, and we find the type of the M protein. The urine may contain light chains, and they are tested, these light chains, by immunoelectrophoresis or a simple test called the Ben-Jones protein test. Osteolytic bone lesions can be seen by radiology or by MRI or PET scan of the skeleton. And the most important is to confirm the presence of abnormal plasma cells. The plasma cells in the bone marrow should be more than 10% to diagnose plasma cell myeloma, or we may find the plasma cells in an extra medullary lesion, like a lesion in the spine or in the skull or in the ribs. If we take a biopsy, we will find infiltration by plasma cells. The diagnosis depends on finding the triad of myeloma, marrow plasma cytosis more than 10%, with lytic bone lesions, and serum or urine M component. In this photo, we can see on the left normal serum protein electrophoresis. On the right side, we find abnormal serum protein electrophoresis. We have two peaks. One is for the albumin and one for the gamma globulins, indicating what is called the M protein. And in this photo, we find multiple osteolytic lesions present in the skull and in the humerus of the patient. And the bone marrow will show infiltration by plasma cells. The plasma cells are large cells with blue cytoplasm and eosinophilic nucleus, which is eccentric. That's to say, it is situated to the side of the cell. It is not central in the cell. The treatment, the most important is the supportive treatment, which includes good hydration, correction of anemia. We use allopurinol to prevent renal impairment by the hyperuricemia, and we may use zoledronic acid to decrease the level of the serum calcium. In patients with hypercalcemia, of course. Chemotherapy, it is not curable, but induces remission and may prolong survival. These include these immune modulators like thalidomide and lenalidomide, and the potassium inhibitor, the bortezomib, the classical chemotherapeutic agents like the melphalan, which is alkylating agent, and prednisolone, or the what is called the VAD regime, which contains the vincristine, vincalciloid, doxorubicin, which is cytotoxic, classical cytotoxic, and dexamethasone, which is a powerful corticosteroid. Radiotherapy is used for localized bone lesions or fractures, and autologous bone marrow transplant is given to the patient after achieving remission with the initial treatment with bortezomib or lenalidomide. The poor prognostic factors in multiple myeloma includes low serum albumin, serum creatinine, increased serum creatinine, that's to say renal impairment if the age is more than 70, because these patients cannot tolerate treatment, increase in the beta-2 microglobulin, increase in the serum calcium if the hemoglobin is less than 10, or there are certain chromosomal abnormalities like translocation 14, chromosome 4 and chromosome 14. Now we come to a condition called the monoclonal gammopathy of undetermined significance. In this condition, the plasma cells are slightly increased in the bone marrow, but they don't reach 10%. This increase occurs commonly in advancing age in asymptomatic people, and the M band is discovered incidentally. The M band is small in size and non-progressive. Usually it is less than 3 gram per deciliter. The bone marrow plasma cells, as I said, should be less than 10%. There are no symptoms. There is no anemia, no renal failure, no hypercalcemia, no lytic bone lesions. 16% of patients with MAGAS will progress to plasma cell myeloma, and therefore these patients they will need observation and they will be managed if they have a progression of the disease. So in conclusion, Hodgkin disease is a neoplasm of B cells that presents mainly with lymphadenopathy. Red stem cells are present in lymph node sections. The disease can be cured by chemo or chemoradiotherapy in a good number of patients. Non-Hodgkin lymphoma is a heterogeneous group of B and less common T lymphocytes. The most important factors that determine behavior is the cell origin and grade. Aggressive B non-Hodgkin lymphoma can be cured by chemo. Some of the patients, of course, can be cured with chemotherapy. A plasma cell myeloma is a malignant disease of the plasma cells. It affects elderly and it is an incurable disease, but can be controlled for a period of time with biological treatment, chemotherapy, and radiotherapy, and autologous bone marrow transplantation. Thank you for listening, and I hope you will go further and read about these interesting diseases.